I would like to thank the SAGES and also the panelists for the privilege of the podium. And my name is Leanne Young. I'm a second-year medical student at the Cleveland Clinic Lerner of College, and today I will be presenting the long-term impact of bariatric surgery in diabetic nephropathy. I also have no disclosures. So bariatric surgery has been shown to resolve and improve diabetes. However, there is very limited literature on the impact of bariatric surgery on complications of diabetes, such as diabetic nephropathy. So the aim of our study was to assess the change in proteinuria as measured by the urine albumin to creatinine ratio after bariatric surgery. This was a retrospective chart review done at a single institution. Our study cohort, we looked at patients who received Roux-en-Y gastric bypass or sleeve gastrectomies from 2005 to 2014. These patients had preoperative type 2 diabetes. We also looked at patients who had preoperative albuminuria as defined as by a urine albumin to creatinine ratio of greater than 30 milligrams per gram. We also looked at patients who had at least 12 months of the urine albumin to creatinine ratio follow-up. And our primary outcome was looking at the median change in the urine albumin to creatinine ratio. Some definitions that we used, we defined microalbuminuria as a urine albumin to creatinine ratio of greater than 30 milligrams per gram, and macroalbuminuria as greater than 300 milligrams per gram. We defined short-term as 1 to 3 years and long-term as 4 to 10 years. And we also defined diabetes remission as a hemoglobin A1C of less than 6.5% with no diabetes medications. And just as a point of comparison, the American Diabetes Association's goal for glycemic control is a hemoglobin A1C of less than 7%. And these were some of the statistics that we used to analyze our data. In terms of our baseline patient characteristics, we had a total of 101 patients. Their average age was 51, and 56% of the patients were female. We had 75 Roux-en-Y gastric bypass patients and 26 sleeve gastrectomy patients. The average follow-up was 61 months, and 71 out of 101 did have that long-term follow-up. In terms of BMI, the initial preoperative BMI was 43, the initial hemoglobin A1C was 8.4, and the initial serum creatinine was 0.9. And finally, the preoperative urine albumin to creatinine ratio, the median was 80. In terms of the weight loss outcomes, our gastric bypass surgery group had decreases from a baseline of 42 to a long-term BMI of 32. And we also saw our sleeve gastrectomy group have an initial preoperative BMI of 44 decreasing to 37 in the long-term follow-up period. In terms of long-term total weight loss, the gastric bypass group had a 25% total weight loss long-term, whereas the sleeve gastrectomy group had a 16% total weight loss in the long-term follow-up period. Some other outcomes that we looked at, our median hemoglobin A1C decreased from 8 at baseline to 6.4 long-term for the gastric bypass group, and decreased from 8.4 to 6.5 long-term in our sleeve gastrectomy group. We also saw decreases in the median urine albumin to creatinine ratio in our gastric bypass group. In addition, we also saw decreases in the median urine albumin creatinine ratio in our sleeve gastrectomy group. However, we did not notice any changes in the serum creatinine at the short-term or the long-term follow-ups. We also saw no clinically significant changes in the systolic and diastolic blood pressures. However, we did see significantly decreased numbers of diabetes medications during the long-term follow-up period. We also saw a decrease in the percentage of patients who were taking insulin therapy before surgery to long-term follow-up period. And the percentage of patients who were not taking any diabetes medications or insulin increased from 4% at baseline to 33% in the long-term follow-up period. And finally, the percentage of patients who were taking ACE inhibitors or angiotensin receptor blockers decreased from 87% at baseline to 58% in long-term. And as a summary of our results, before surgery, only 24% of patients were achieving the American Diabetes Association's goal of a hemoglobin A1C of less than 7%, but this number increased to over 70% at the short-term and long-term follow-ups. In terms of the patients who had remission of diabetes with the hemoglobin A1C of less than 6.5% and no diabetes medications, over 25% of patients were able to achieve diabetes remission in the short-term and long-term periods. And then in terms of the urine albumin to creatinine ratio, all of our patients had microalbuminuria before surgery, but this percentage decreased to around 50% during the short-term and long-term follow-up periods. And finally, over 75% of patients had improvements in their albuminuria, both in the short-term and the long-term follow-up periods. So some limitations of the study were that it was retrospective, it was performed at a single institution. We did not have a medical control group, and we had some varying follow-up times. And then we did have about 30 patients who did not have long-term follow-up. However, this is the largest series on the long-term improvement of albuminuria after bariatric surgery to date. And our data is suggesting that bariatric surgery may improve the urine albumin to creatinine ratio. We saw that 50% of patients who had albuminuria before surgery did not have albuminuria at the long-term follow-up period. We saw these improvements begin in the short-term follow-up period and continue to be maintained long-term. And one possible mechanism behind this is due to the improved glycemic control that patients were achieving after bariatric surgery. However, one interesting point is that even though the gastric bypass group lost more weight than the sleeve gastrectomy group, there was no difference in terms of albuminuria resolution between these two groups. And so future directions for research would include doing a study, randomized control trial to investigate the effect of bariatric surgery versus medical therapy on improving albuminuria. Okay, thank you.